Hello, everyone, and we are live, I guess, right? Welcome, everyone. Welcome, Sarah. How are you doing?
Good.
We are here for our webinar on healthcare regulatory considerations for AI with Sarah Kramer. And hopefully, we're going to have a good time. We're going to receive quite a lot of helpful information. But as of right now, I hope that everyone is connecting and nobody is having any technical difficulties. But guys, as you're popping in, as you're connecting, please, I don't know, write down something, say hi, say where you're connecting from, and maybe what you're interested in. I already see we have several questions coming in. Sarah will address them either as we go or at the end. But anyways, let us know if you're working on something specifically. Just throw in. Let's get the conversation going on the related topic. And so let me take a moment while you guys are connecting. Let me take a moment for an introduction. I am myself, I am Andrei Kasyanov, and I am a CEO of Glorium Technologies. And at Glorium Technologies, we work mostly with healthcare startups to help them build their digital products. And in our line of work, pretty much we're holding tons of different conversations with different startups. We built over 100 different products in healthcare area. And recently, with all this hype, all those many questions around artificial intelligence, we we started getting lots of questions from our existing clients, from potential clients, everything around artificial intelligence, and we just do not possess all of the knowledge. So that's the reason we organize this series of webinar where we invite knowledgeable speakers, somebody who worked in the trenches, who already faced certain level of the problems, and we ask them to present the actionable, real information that you, our audience, or anyone, even if you're not among our clients or not even thinking, but you can learn something, you can get something actionable. We like adding the value into our community, not only doing the business but also building the community and helping startups, especially at these difficult times, as we know, as the funding has dried out. So in addition to all of the technical and regulatory challenges, all of the startups also got additional financial headaches. So at least something you want to take off your shoulders. So, and today we have Sarah Kramer, who will actually. Why am I doing this, Sarah? I'm sure you're capable of introducing yourself and also talking. Just give us a little bit of a teaser. What are you going to talk about today?
Sure. Yeah, and I'm already looking at
Mm-hmm.
the chat there, and so many interesting questions. But I think just to set expectations, I've got about 30 minutes of material. It's pretty jam packed. I'm going to try to get through it all, but I'm really going to speak from the lens of having been more on the implementation side in the healthcare industry. So, and really talk about the continuity of how the regulatory apparatus, at least within the US market, is likely to absorb AI. So, I think one of the themes you'll hear is that we'll be speaking in terms of an evolution. Um, can folks see my slides? My
Mm,
introductory?
yes, we
Yes,
don't
all
see
right.
now. Yes, okay.
Okay, yes. I might have a slight lag, so I'll check in, but this is just
Mhm.
a little bit of my introduction slide. And again, I come at this really from a healthcare delivery side. I have been in the informatics space for over 20 years, and over that time, got involved more and more on the compliance side, but I would say more in a translational sense. I'm not a lawyer, I'm not a compliance officer. I've always been more in that translational space of how do we take that technology and make it usable essentially at the bedside or in the clinician's office. And I wouldn't say there was like something that just turned on and said, oh, wow, I'm in the AI space now, but it's something that has sort of crept into the technology, really starting with more of those large statistical models that were generated predictive algorithms for patient care in the place of, say, sepsis. And then more recently, the using technology we already had in terms of voice recognition, the vendors have been bringing in things like the ambient note generation, and also on the radiology space, we've seen a huge expansion in terms of what's available for automated interpretation. I could go into other areas like, laboratory medicine and liquid biopsy, but that's not historically my role. So I'm going to really speak more on the health information side and a little bit on the medical device side. So this is because I've spent my entire career within the U.S. We're going to be speaking about U.S. federal legislation, and but always keep in mind that individual states may have more restrictive laws. Always get actual formal legal advice when needed. Everything I'm going to speak to is pretty much public domain, and I will have lots of links at the end of the talk for doing your own research. And this is strictly my own opinions, and I have no conflicts of interest to disclose. So as I mentioned, I've only got about 30 minutes to get through this. It will seem rather fast, but hopefully I can paint a story of how healthcare legislation has evolved and why this is tied to things like the US budgetary cycle that makes it very difficult to radically change. So we're going to see there's some sort of set rails that these things run on. And more importantly, kind of over my years of understanding the legislation and even attempting to influence legislation, how you kind of read the tea leaves and understand kind of the policy intention. And then give you some tools for how to follow this and participate in it and be on the alert for both opportunities as well as competitive threats. So I'm going to leave to you. I'm assuming most of you are more on the development space, but if not, I think most of you are familiar with the SWOT analysis idea. I'm going to leave the strengths and weaknesses of your respective technologies to you. But on the regulatory space, I think we will see the story of where it can create huge opportunities, but more importantly, can also create significant threats, whether that be liability or markets going in a totally different direction. And I'm going to start with kind of a little bit of a story. Hope this doesn't seem too jumbled. And it really starts in 2014, which was not long after meaningful use had been implemented. And there was a new law that required a specific health information technology around clinical decision support. I'm not going into the details or naming names. If you see my LinkedIn profile, I did do a little blurb on this, but I want to keep this a bit more agnostic and speak about the system, not necessarily, this one particular case. But, when a new law is introduced, normally they give it a 2 or 3 year ramp to start enforcement. And originally it was hoped that by January 2017 that would start. And then as people attempted to implement this, there were a series of snags. People were in these long trials. And then as we dragged into 2020, COVID hit. And literally just as of earlier this month, an updated regulatory package was put through that essentially rescinded this requirement. And in that, not only were health systems trying to implement this for a long time, but I counted 9 separate vendors at least that were approved by CMS. So this was, quite an investment on both the vendor side as well as the healthcare side. And this is what I think I'd like to see avoided. So this is really a scope of what we're going to get at. I saw some comments about IRBs and WHO and stuff. And I find that these 5 key milestones have put together the framework that I think will be enduring for some time. And I'm going to key that right back to the HIPAA laws of 1996, which radically changed our understanding of health records and the rights of patients. And then we'll go through the High Tech Act that launched the whole meaningful use process, and then some physician payment reform, more recently the 21st Century Cures Act, and then spent a bit of time on medical device and software as a medical device, which is very pertinent to AI.
So you think, sorry, I'll
No, go
just
right
chime
ahead.
in. So, so you think those laws will continue evolving?
Yes,
Or
yes, and I'll explain why I do believe that those laws are going to be very durable, especially this first one, which was essentially created as a civil right that is protected by the Office of Civil Rights in the U.S. And I don't think there's I don't expect that once these are put in place, that they're going to change. Instead, we will see them evolve and start to recognize emerging technology.
so you don't think anything new is going to appear on our landscape and something else, additional headache
Oh,
that we all
I
need
think there
to
will be.
start worrying about?
I think there will be, but yeah, hold that thought. I do feel that we are going to see existing regulatory mechanisms evolve and absorb a lot of AI, and a lot of that has to do with how at least the U.S. market is funded, and it's because Medicare is such a huge purse for funding healthcare, and so a lot of this goes into really the annual budgetary cycle. And it's also kind of what Congress is used to, right? When we look at how the U.S. government is structured, this leverages laws that are already kind of have stood the test of time. They are not likely to be overthrown by the Supreme Court. Does that make sense?
Yeah, it does.
Yes. So
Okay.
yeah, I'm sorry. I know I'm going to keep this fairly high level, but hopefully we'll have more time for details at the end, and it'll make more sense as I've gone
Yes,
through.
would be great then to dive into some probably more details about AI.
Yeah.
So
Yes. Yes, for sure. And even though when HIPAA was created, it predated AI by quite a bit. What's interesting about the P, it's not two P's, it's only one P in HIPAA, and that P stands for portability. And so I think although AI does, developers need to be aware of some of the restrictions, especially around inadvertent release of personal health information. I do a quick call out on the minimum cell problem, which is if you've got a large data model and you've got a number of things such as language, age, zip code, in combination, you can get down to being able to theoretically identify or de-identify or re-identify anonymized data if you're combining things like an 88-year-old female who speaks Tagalog that's in a small town in Minnesota, right? So, but more importantly, I think when we talk about the portability, it gets down to the fact that patients have the right to access their own health data, and that all clinicians that are treating the patient must be granted access to relevant health information, and that the patients have the right to share that information with whomever they choose. And I think as we see these evolving cloud-based data marts, this is opening up a market for patients to kind of share their data with developers, whether it be Apple or Google or Amazon. And I think that will spur a lot of interesting trends in the use of AI in healthcare, not just through the health systems, but also through kind of, I would say, the life hacker community. The next big, really the beginning of, I would say, true high health IT legislation started in 2009. And what's important about this is it created financial incentives via Medicare and Medicaid. And the government invested, roughly 30 billion. And then of course you can multiply that several times on what was invested by healthcare systems. Because of course, healthcare systems were doing health IT before there were these incentives. But it also created a framework for these standardized terminologies around diagnosis codes, lab, pharmacies, and a real push on a policy side for vendor agnostic interoperability, which again, from an AI lens, that's kind of the platform that then you can have your sort of freestanding AI engines through like a web API interface, suck in data, process it in the cloud, and then bring it back to the designated audience, whether that be a clinician or perhaps the patient directly. And so this is just kind of shows how just in the space of 2 years, there was a huge bump, especially on the hospital side. And that has largely leveled off at about 97% in terms of fully implemented. Even non-fully implemented hospitals, I think, have some degree of automation, whether that be in pharmacy or lab. It's just this is those that met the definition of a fully integrated system. You'll notice the physicians sort of lagged a little bit on that. So there became some sort of separate pushes for incentivizing use of IT within the physician offices. And this was done through physician payment form. And what happened was in 2005, a new law kind of replaced an older claims-based physician quality reporting system. And it also absorbed the physician office component of meaningful use. And it split it into two sort of streams. One is recognizing that most of the US market uses a sort of fee-for-service type of reimbursement, but also encouraged shared risk models like those that have been used by Geisinger and Kaiser. And those all got merged under a single payment program. And the idea was to nudge gradually away for compensating on the base of sort of the time or effort used in the care, and instead look towards value to the patient especially. And this is based on an idea that was published by the Institute for Healthcare Improvement back in 2008. And they labeled it the triple aim. Some people have tried to add fourth and fifth aims to this, but I still think that the original triple aim is the thing that really drives this regulatory evolution. And it's the idea that through targeted funding and incentives or penalties, we can improve the health of the population, deliver a great experience of care, and do it at the lowest per capita cost.
And what do you think? Is it working?
That's a great question. There's a lot of debate on that. I think that it has been a boon for data. We have huge aggregate data sets. Whether it has actually, and there are some things I think we could point to in terms of the patient experience, like patient portals are ubiquitous now. People know that they can get their lab results through a patient portal. And they can track their labs over time on an app, right? Most of us probably have an app on our phone that we can use to track our health and message our physicians. But I think the jury's still out, and there's a lot of, I did see something about IRB in the chat earlier, and I think there is a lot of good research that's being done right now to try to evaluate how well this is working. But again, the policy intent is unlikely to change.
Yep.
So now we move to the 21st Century Cures Act. So this is where things are coming hard and fast, right? We talk about 2012, 2014, 2015. This is the 2016 law. And this was really designed to spur innovations in a lot of things, not just healthcare IT. But I think from an AI development, what this kind of brought to the mix was a new concept called information blocking. So this is taking HIPAA to its next logical step. And it starts to not only say patients are guaranteed rights to their data and the portability of health information, but it also started to establish really line items on what would be considered inappropriate hoarding of information, essentially. And this was the mandate that then said all clinician notes will be published through patient portals, with a few exceptions. Diagnostic test results went from being released. The original standard was it had to be released within 30 days. And then they said, no, we're done. Like, it all has to be released in real time. And then this created a set of standards related to the developers of certified health IT. Now, in my experience, and others may have seen something different, most AI development is not occurring in that certified health IT space. I do expect that this will change and that there will be a push to really have a full certification process for that. We're already there on the FDA side, but this would be more on the Office of the National Coordinator through the HITECH Act apparatus. And this is just a little infographic on the exceptions to information blocking. And I called out two of them that I think are going to be mostly impacted by AI. And those are in the realms of whether something is technically feasible and whether it degrades, it's permissible to block information because it would otherwise degrade the performance of the electronic health record. And so in other words, if you can do it technically, you must do it. And I think a practical application of that, which is not AI, but has a lot of the same limitations in terms of the need for cloud storage architecture, is which health systems currently publish radiology images through their portals versus those that are still printing on CD. I've been at health systems that were able to turn on web sharing of images fairly quickly, others that struggled, and all had to do with that, how they were architected for storing their images. And I think it'll be an open question as we start to see more and more AI that is in stream with the clinical experience, how much of that will then need to be disclosed to the patient through the patient portal.
So what you're saying is that basically, as we continue with AI development down the road, if there are any internal considerations, intermediary output that is produced by AI systems in between, but that is directly related to the patient, it must be disclosed to the patient.
Yes, we are not there yet, but I can foresee that happening. And I would use the example of, say, that you've got a radiology AI solution for rapid detection of stroke. This is obviously important to help get the patient definitive care. Will that model or that warning need to be disclosed to the patient? I don't think that has become settled, but I would predict that that's the direction that we're going to see the regulation go, that if you have AI engines running, that the patient will have a right to see what those calculations look like. Right now, they only display to the treating clinicians.
Interesting. So basically, if there are any potential flags raised by AI systems that are in between, patient has the right to know them. And now you're saying not only has the right, but you must provide him this ability.
Yes. Yeah. I mean, I know that as people are implementing these ambient note generating software, you do have to disclose to the patient and get their permission to be recorded. The question will come up is, will the patient only see the final note, or would there be a situation where they would have a right to see the transcript? These are all, I think, open questions, but this is why I do feel that we're going to see gradual evolution as we understand kind of existing law and how that would be applied in using the principles of the patient right to their data. Does that make sense?
It does.
Okay.
Poses additional questions, of course.
Yes.
And it's an additional, I would say, burden.
It can be, yes.
But yeah, more or less understood. All right, so let's go.
Yeah. And it's unclear. Again, there have been cases, a good example where information blocking is justified. I think the argument will be whether or not there's any risk of harm to the patient by sharing kind of more raw, uninterpreted information. And I think that's a good segue to this topic here about software as a medical device, which was developed as an international concept in 2013 and really became part of U.S. law in 2017 when the FDA released guidance and for what they call their pre-market notifications prior to releasing software changes in an existing device. So imagine the software that's, say, embedded in an EKG machine or a lab device. So that's where this 2017 change in the law was made. And more recently, they've put forward a discussion paper. I will have links to a lot of this at the end. I didn't see that maybe somebody in the audience knows this, but I did not see that they have really formalized this. I think the FDA is still kind of struggling with how to execute this. But they did publish, at least here's kind of like their model of how this works. Hopefully you're seeing like the slide that shows what those inputs look like, how the algorithm works, and then what the output is. And what's interesting is, you have to think about the difference between, say, a static algorithm, like those ones that have been implemented for many years in electronic health records, say like about predicting sepsis or deterioration. Those static algorithms are fit much more easily into the FDA paradigm. What's tricky is when you have more of a continuous learning environment where that algorithm is not going to be set in stone. And I'll address that a bit at the next slide, but I wanted to also call out this risk grid and some of the gray areas there. In the case of, say, radiology AI that's detecting something like a stroke or detecting a critical aortic aneurysm, you can imagine the FDA is going to be most nervous if the software is starting to recommend treatment or kind of call out a diagnosis. So instead, we see is kind of people wanting to stay more on the informing a physician what's going on and letting the physician still maintain control.
And this is kind of as purely, and say, in my opinion, majority of the systems that we have right now on AI side, and they're done in this way only because of the regulatory hurdles.
Yes.
Basically, you need to go very far in proving that your system works and works properly, and then also take the liability for the result of it. And for that reason, we have the majority, pretty much, well, of course, not all, but absolute majority of the decisions, they only, they basically, those are, say, they help in decision making. So, but they're not, they do not position those systems as decisions themselves. So you cannot rely to them as decisions. It's only and mostly because of the additional hurdles to certify those systems.
Yes.
And so the output is a recommendation, and the physicians basically have to take an additional review and step in order to make final decision. And I saw it happening even in simple cases. So we still have quite a long way to go with all of this.
Yeah, and it's interesting that they even call out that even if your modification reduces risk, you still have to go through this formal application. Currently, it's been largely the electronic health records have not been under this regime. One of my predictions, I think that will change, because as I've seen how some of the health records developers are looking to do things like chart summarization using natural language processing and large language models to maybe present a different skin of the EHR based upon whether you're an orthopedist or a neurologist. This is going to start taking them in a little bit of a slippery slope of the machine sort of making decisions on what's relevant based on specialty. So that'll be another interesting thing to watch, is whether these principles kind of migrate back more into the EHR space. But yeah, as you kind of called out, Andre, you do get this sort of design freeze where the FDA is really struggling with how to use continuous machine learning models, especially as those AI engines may not be very transparent in disclosing how they are evolving, right? There's a little bit of a black box element that makes the FDA obviously very nervous. So instead, they have been sort of steering people towards more alerting and informing, saying, hey, I think there's a stroke here. You'll want to look at it. And but it does stand in some tension with, again, that HIPAA law that really guarantees, liberating patients to data. And so when you think about it, like if I'm a hospital or I'm a medical device maker, I'm under significant regulatory limitations in how to use AI. On the other hand, we've created a framework where basically patients can go, they can take their data and do anything with it. So I think we're going to see my prediction on this is we're going to see more interest in, again, these personal health records that are then going to become AI enabled, because the patients can use their data however they want. Does that make sense?
Yep. Agree. Okay.
Yes. So this will be very interesting.
It's
I mean,
yeah.
obviously, if you're in the health IT space, you get the benefit of selling a commercial product to deep-pocketed organizations that are willing to share, seven-figure licensing agreements. But the consumer environment is going to be where I think it will create some pressure ultimately. Trying to get through the last 5-10 minutes.
So basically, you're
Yeah.
saying that, sorry,
No,
I'll
go
interrupt
ahead.
you, that it is easier, like if you're thinking about a new product, building a new system, a medical device based on AI specifically, but from what I see, it's true both for AI and non-AI system, that it's better to have it targeted to the large health systems than to the consumers. You'll be in less regulatory hurdles, basically.
Correct.
Is that?
Yeah, I mean, basically, you get we've talked about the billions of dollars that have been spent in health IT. These are huge markets, and we will need to continue to have. I expect we will see continued growth of AI in use of medical devices in the radiology and lab space. But if there's, for some of the really cutting edge stuff, I think what will put pressure on it is as we see more of kind of the health hacker and the direct to consumer movement drive innovation that we may see come back into the healthcare. The FDA may need to get pushed by having healthcare innovation occur outside of the regulatory framework. I'm not sure if I'm saying that very well. I will use an analogy of kind of what happened with the open notes movement. Open notes became a regulatory requirement as a result of the 21st Century Cures Act. But before that, it was a movement that nonprofits had been behind and socializing and pushing health systems to voluntarily release notes. And I could see a certain thing, I could see this happening a lot in the AI space, where patients can take their own lab data, sort of pool it essentially in a data co-op, and be under no constraints whatsoever to develop, machine learning models against that. And then in the middle space, the EHR vendors also have huge anonymized data sets. They're trying to figure out what to do with that. So we'll see these competing forces shaking out over the next decade, I think.
Interesting. Okay. More or less clear. Thanks.
Yes. So other like fresh legislation, there is a task force that's been stood up at a national level, but it's really not specific to healthcare, and I don't expect it to significantly change what's already in flight for healthcare, including things like the TEFCA agreement that went live just this month. But I do think that, as I've mentioned, we will see a lot of interesting conversation and policy related to patients' rights, both to own and share their data. But the other one is, how transparent are we with patients on what we're doing with their data? I know a lot of patients, you sign in the hospital, they make you sign these forms, and a lot of times that condition of admission statement says yes, and we're gonna take your data too. I expect we're gonna see some pushback for that over time, especially as those data sets become monetized. A few other things that just I think impact is a force is then this evolving case law, both for medical malpractice and recently hit the news that insurance companies can be held liable for using AI, and this gets back to that risk grid, right? Because as I understand how these AI models are being used in the insurance space, and I have no direct experience with this, I think the concern is that the AI machine is getting into that diagnosis and recommendation space without having that licensed physician overseeing it. So this is another area to watch. I'm going to close.
So you're saying, as of right now, the insurance companies, they are free to apply artificial intelligence without any regulation in order to help them or even make decisions about whether they want to pay for the case, for the treatment, or they don't.
Yeah. Yes. And another way to frame that is there are certainly parts of the healthcare industry that are not covered by things like HIPAA because they're not considered healthcare providers. So a pure payer is allowed to use essentially actuarial software, right? That's not. But as you start to have AI come in there, is it behaving as actuarial software, or is it starting to make treatment recommendations, which starts to get a little bit
Yeah,
into.
okay.
Yeah.
So, hey, all the startup founders out there. So here is an idea, a good one for you, a business model. You don't have to go through the regulatory hurdles if you make a software for the insurance companies and help them make decisions using AI. Go ahead, now, anyone, feel free to pick out the model and use it.
Or supply chain. That's a big one. The pharmacy
Or
supply chain already hugely uses AI.
And you don't have to care from what you're saying. In the foreseeable future, you don't see anyone anything that is coming up in terms of regulation of the AI usage in their space.
I'm not sure.
So I'm just saying that if we take the insurance, for example, you don't see any regulatory movements that will make them regulate the AI usage in decision-making process.
I predict on the basis of some of these lawsuits that we will see some changes, especially as insurance there's one of the you have kind of pure insurance companies, but a lot of insurance companies also are starting to become sort of payviders. They are opening their own clinics, stuff like that. So I think we will see evolving legislation that will hold insurance companies more accountable for making determinations of patient care without having kind of an independent licensed practitioner oversee that, or at least it would have to be transparent. That's again that whole transparency thing that the insurance will have to disclose that what's being used.
Yeah, but for now the window is open.
Yes, okay. This is very fast evolving. I did want to touch again on why these regimes are so difficult to change. And one is because you have at least 3 separate annual funding cycles that set the physician fees, the inpatient hospital reimbursement models, and then those sort of hospital, outpatient, and nursing home models. All of those are part of the funding cycle, and that's where things like incentives and penalties are built into it, which is why so typically, because these all kind of kick in January of the calendar year, is how the funding cycle goes, you will usually see the proposed rules get released over the mid-year and then finalized usually in late November, early December. And that the first one there that related to the MIPS, promoting interoperability, that was the final rule for 2023, effective 2024, that killed that piece of decision-making software that I referenced earlier in the talk. The one that's kind of ad hoc is HIPAA updates. They are often embedded in other things. And an example of that was I was back in 2024, I was looking, for some reason, I was looking at the Clinical Laboratory Improvement Act because it had some HIPAA updates. And that was the one that first time that I saw that patients were then given rights to get their results directly from the lab without having to go through a gatekeeper like a hospital or a physician's office. So you can often see a lot of interesting stuff happening that way. These, as I alluded to, these regulations, they are released as a proposed rule, and then there's a several-month window where you can comment on them. And I've done this myself. I've done at least 2 or 3 formal commentaries, usually on behalf of whoever I was working for at the time. And I think that I actually did comment on that law that ended up getting indefinitely postponed. And it's always good when you're doing
this. Hope it wasn't because of your comment.
No, I did go back and read. No, I don't think it was just my comment. Although I remember at the time, part of what was making me concerned about it was that I felt that it was too much of a standalone solution. And in my commentary, I referenced sort of the evolving kind of AI-driven, because I sort of saw where things were going, and I felt that the solution was already becoming technically obsolete. But it got killed off for other reasons, mostly just having to do with it was trying too hard to change physician behavior, and quite frankly there were no monetary incentives behind it, so it only had penalties. So I won't go into the details, but there's a nice guide that I've linked here. It's from the Department of Labor, but it applies to all the regulatory agencies, and here's your one-stop shop for following evolving legislation. You can search by terms like information blocking or AI, whatever you want to do. You can look just for proposed rules. You can, look for, search by agency like FDA, or in this case, Centers for Medicare and Medicaid. And even if you don't have any criticism, it's not a bad idea to go in and do a comment and say, hey, I looked at this and I like it. I think this is great. For that, I might just do an informal, hit kind of the like and subscribe button, as they say. But if you are going to do more of a data-driven counter argument, it's probably good to do with a more formal written letter with your letterhead and upload as a PDF. So a lot of material here, and I can't wait to get to the Q&A. But I hope what you come away with is these core principles, especially, I can't say it enough, that patients have the right to their health information, including how it is gathered, digested, and released. This is not going to change. It's just understanding how AI will change that. I don't expect a new regulatory body to arise for generative AI in healthcare. I think it will be addressed through these existing mechanisms. I think that we see in general, federal policymakers in the healthcare space, lovely. I mean, these are very, very thoughtful people. There's a sense that GAI really can achieve that triple aim around cost, quality, and experience. But they need a lot of feedback. So please take advantage of the ability to review and comment on evolving regulations so that you have a voice. And here's just how to reach me. I think everyone saw my LinkedIn contact, and hopefully we'll get these slides posted. I've got some additional resources that are deeper dives and then references that on some of the other topic I hit. So thank you.
Okay, so actually let's go into some free-form conversation here probably, so I have my own first question, and while I'm asking, while we're talking, guys, anyone who's online, don't hesitate, put your questions, ask your questions. We'll see them in the comments, and we'll try to discuss in the remaining time. But Sarah, let's it's all good, great overview, awesome, all of the legislations, laws, and everything. But now I'm trying to imagine myself as a startup founder, as somebody who wants to implement a product, or has already developed a product partially, and who needs to release it and get the approval. So from what I understand, I feel that I need an approval. But and I listened to your webinar. I listened to all this information. My head is exploding right now, honestly. What are you talking about? I only have this tool that uses a standard language model, or maybe standard, some other visual model. I just want to help those poor doctors do this little thing. And what are you doing right now? Do you have any specific comments? Any sort of a simple algorithm that I am as a founder, that as a founder can follow, just in order to determine my next steps, not necessarily solve the problem and answer all the questions, but at least to understand what do I need to do next.
Yeah, no, that's the $20 million question, right? I think that in the smaller, innovative AI space, I think there's probably most of the folks on this call are more going to be in that selling to a larger company. So are you going to essentially license your solution through an existing electronic health record, right? I think it's very difficult to break into the new healthcare record space, but are you going to sell to like an Epic or a Cerner, or are you going to partner with a Philips or a Baxter, right, in that medical device space? That way you're going to leverage their regulatory know-how, they've got lawyers, they've got compliance folks. So selling within kind of the established space is probably going to be one good way to enter. I certainly see a pathway also through certain universities. There's many, I don't need to name them, probably most of the people call them, is that there's a lot of cool stuff going on within the academic space. And again, you're going to then leverage the compliance folks, the IRB folks. So thinking about who can be that bigger partner that can take your product to market, I think is probably the most realistic pathway for most.
So basically, you're saying that if you're on your own, you're on your own, and you have to do everything yourself. But the most viable way for the best business model, you're saying, for any sort of the AI-driven decision support systems, diagnostic systems, something that has a certain level of FDA approval, it is much better to get into a partnership with somebody more established in the industry and use them as the channel partner in order to do at least an initial rollout, and then you can, as you become stronger, then you can choose a different path.
Yeah.
That's your
and part of that
advice.
is because again, the HITAC Act and these things that pushed for electronic health to be vendor agnostic, I think they were really pushed and to make it more so that you can have more of these modular plug and play solutions that could be put within these larger EHR systems or medical device systems. And realistically, if you're looking at a very large established software company, they may want to do AI development, but it's difficult sometimes to change the culture, right, of a very large, mature organization. So that's where I think smaller developers have the advantage, where they can kind of, they have the nimbleness, and then they can partner with different vendors as essentially, again, a modular plug-in solution, or go that direct-to-consumer route, which I think is also something that would take more time, but I think is something where there's fewer barriers to introducing technology.
Okay, understood. Thanks. Let's try to go through several questions that we have from the audience. The first one is from Mattis Veld. So I'm interested in how the IRBs are accommodating AI and tech advances to reduce redundancies and streamline study reporting outcomes that focus on patient safety. Anything you can comment on this?
I should probably connect you, Andre, with some experts I know in this field. I've not really been directly involved in the IRB, but I've spoken to people about it. I think that we will just see an extension of kind of what are the principles of an IRB. It sounds like, again, it gets back to, are the patient and, humans, is it related to human subjects or not? And, and if you have to go down that human subjects pathway versus other areas in AI, they studiously avoid having to involve human subjects and just use large anonymized data sets.
Okay, so is it fair for me to say that give a message to Mattis to reach out directly to you to continue on this topic?
Yeah,
and you can
sure.
do the introductions if
Yes.
needed. All right, good. So what else do we have? The practical application is from Adrian Lee. What the practical application is what we okay, sorry. That was probably the comments as we were talking.
I would like to address the one about AI implementation for vulnerable populations. I just saw that pop up.
Okay.
That is a really hot topic. And again, gets back to kind of healthcare policymakers. I do think that we will see AI being used to, find underserved communities. The thing that is interesting about that, though, is that there's a separate kind of stream of conversation on the HIPAA side about the right for patients to, again, shield certain sensitive information. You see this, I think, especially in kind of the sexual orientation and gender identity space, where there's a kind of a lively conversation about the benefits of using data models to reach these populations, while at the same time allowing patients to opt out and choose not to disclose certain pieces of sensitive information. But I think that, yes, there will be I see a lot of promise, and there's a lot of interesting conversation going on in the policy space for that. I just haven't seen, like, one would be like geomapping would definitely be one. I was having a conversation about even just helping to match make within like a rural area, what's the best place to find care, the shortest distance to get there, what could be done telehealth. So I think in the matchmaking space and access space, AI might be very powerful, especially because of its ability to ingest geolocation information.
Well, there are many other different ways and applications, especially for AI. I don't know, in fault detection, in detection of the behaviors within the. I just recently was at a conference. There were actually a number of different combined software and hardware solutions that were helping pretty much just to watch the elderly population in the nursing homes and understanding basically their behavior and raising alarms if the behavior changes. So
Yes.
and this is what they also, we spoke with a few companies. They basically they have the systems installed in the nursery homes, and the questions are, they're saying, hey, the nurse knows that this particular patient, so he gets up every morning at 8 a.m. or between 8 and 8:30, and then, I don't know, does whatever he needs to do. But just tell me, I don't want to come and check on him every time. Just tell me if
Yeah.
he didn't get up by 8:30. So, and this is a very helpful information that we can provide and tell, hey, something is wrong. Maybe everything is right, but something is wrong, at least a flag. Go and check on him. So, and there are all sorts of different habits like that that you can figure out in user behavior, in patient behavior. And you can actually detect this behavior and at least raise the questions and say, hey, it makes sense to check.
Yeah.
So things like that I saw.
Yeah, no, one of the solutions that I was helping to implement this year was around using radiology AI data, but using it at a population health and managing conditions that are not immediately life-threatening, but can kind of fall through the cracks. So we were trying to figure out how to use this and do patient outreach on things like, I got seen in the emergency room. I got a CAT scan done to make sure, and in the course of getting that CAT scan, oh, by the way, there's this, dime-sized lesion in the lung, and that those kind of cases in the past could have kind of fallen through the cracks, right? Because it wasn't the responsibility of the emergency room physician to address this, and the patient may not be connected with someone to follow up on that. So I think there's implications in that. I've seen, to your point, stuff related to ambient motion sensors as well as bed sensors to detect patients trying to get out of bed unassisted. Yeah, it's those are all great examples.
Yep.
Yeah.
Okay, so what else? Yeah, so we have some more comments coming in, but yeah, everyone is reading. I'm thinking if we have skipped anything that's worth talking about. What else was here? Probably nothing. I'm just going through the comments. Actually, there was one. I'm not sure, Saren, tell me if you want to make any comments here. It's Brendan Smith. I'm interested in how the FDA, WHO, CDC, NIH, etc., are involved in the tech trends.
Yeah, yeah, thanks, Brandon. Certainly the FDA has a big role in this, and bears close watching because AI is probably disrupting their historical paradigm. NIH is getting funding through the 21st Century Cures Act. I think we will see NIH, again, because it's such a huge topic, I really didn't go into kind of the liquid biopsy conversations. But that's going to be very interesting, and because it's so impactful for we're both in the radiology space and in the lab medicine space. AI is allowing the discovery of so much more information than was expected. And we're going to see this whole paradigm of, well, if I'm ordering this test for X and it finds Y and Z, and it's who really owns that, and how do you disclose that to the patient? And do you disclose it? How do you disclose the underlying technology to the patient that discovered maybe like a potential cancer through one of these scans or one of these blood tests? So it's going to change I think it's going to, there's a potential for disruption of sort of the traditional doctor-patient dyad solution. As we said, the FDA is really dependent on the idea that there's going to be a doctor that's going to interpret this AI solution and deliver it to the patient, but we're going to get way outside the comfort zone of most physicians. I was a family doc, just treating sprained ankles and sore throats when I'm, and now I'm, my colleagues would be in the space of saying, oh, now I've got like this test that's showing 20 different potential health concerns and I'm way out of my element. So that'll be an interesting development to see how that's handled, and whether we have to kind of expand telehealth to sort of have these, niche experts that can help interpret these tests for, the average primary care nurse practitioner or PA out in the wild of Alaska.
Yeah. Okay. So I think probably the last thing that I want to say. So we have time running out. Oh, and you know what? I want to apologize to Erica Harris. I think we have some software glitch, and it was all of her posts came to us into the application under different names. I have no idea what happened. So it was Erica. I'm sorry. So, and there is another question. Let me see. What else? My question about AI optimized geometries for custom devices addressed. Are there best practices for remaining regulatory compliant in this area? Oh my God, I don't know. The questions keep coming. I don't know, Sarah, if you want to answer or just skip or take the conversation offline.
I think all I could say is I I think just if folks give feedback on this and they'd like to see other topics, maybe I could come back, or I certainly have many peers in the industry that are deeper experts in various topics. So maybe I can refer a friend or colleague to Andre for a future webinar.
Okay, so the simple answer is, guys, don't hesitate. Connect with Sarah on LinkedIn. Continue the conversation, and also Sarah, as maybe if you want to say a couple of words, I know you are an active consultant in this area. I know you're doing this. Basically, it's part of your business, from what I understand, right?
Yes.
So pretty much you have the existing blueprints and existing templates of solving this kind of problems and answering the questions. I'm not sure if you want to give say a couple of words about what you do for our audience if they get interested in what you do.
Sure, I appreciate that, Andre. Yeah, I spent again most of my time in the healthcare delivery space, the last kind of 10 years of my career in kind of associate CMIO roles, working in that translational space. And I think there's a real change in the industry right now. Most of the big EHR installs have been done, and I really wanted to be able to work more as a free agent, because to help advise and act as that translational role for pretty much whoever needs my assistance, and so I'm a free agent, I guess.
Okay, that's great. So anyone who's interested, you're definitely welcome to connect with Sarah and continue the conversation directly. So I'm gonna wrap it up. Sarah, thank you very much. That was interesting, and you see the audience was really active, asking questions. So I think we hit quite an interesting topic on this one. So hopefully we were able to cover at least the beginning, just for people to start understanding where to go. Of course, you cannot cover everything, but at least the overview is there for our audience, and they know at least where to look at or where to go. Use your services directly in order to help them answer their regulatory and compliance questions around AI. And guys, audience, you were awesome today. Thank you very much for all your questions, for all your active participation. And just for you to let you know, so all of those webinars, they are recorded. And for all the registered users, you will get a follow-up email with the link to watch the webinar if you want to, and basically see additional details or review the information that Sarah has provided to you over here. And I also want to remind that this is a series of webinars. This is not a one-off. We are doing a series of AI-related webinars, and the next one, if my memory doesn't fail me, is going to be on January 19th. We're normally doing one once a month, and it's going to be you know what? I'm not gonna announce. I don't exactly remember the topic, so I'm not gonna spoil it. But everyone who is subscribed to our mailing list, you are getting announcements and information about the upcoming webinars. So stay tuned. And for all of you with whom I'm not gonna talk until the next year, it's Happy New Year, Happy Holiday season. I hope everyone is going to enjoy the family time, the downtime, and we'll continue pushing forward in the next year. And Sarah, again, thank you very much, and all the best to you.
My pleasure.
Thank you. Bye-bye.